Okay. Welcome to the closing session of our 2022 Skirboll Conference. Thank you for joining us on this beautiful Saturday. So far this conference, we've heard about sensory processing and health equity and diversity initiatives. And as a reminder, the presentations are recorded, and so you can go back and watch any that you might have missed or that you want to revisit. And today we have the opportunity to hear an excellent session on a really important topic. So we will be talking about ADHD and autism and drawing some connections between behavior, biology, and intervention. First, I'll just take us through a few housekeeping issues. So again, as always, we want to dedicate our conference to Mr. Morton Skirboll, who generously support the conference, and thank them, the Skirboll family, for supporting today's event, as well as the Rochester Regional Center for Autism and the Ibero-American Action League for providing Spanish interpretation. Which brings me to, we have sign language interpretation that should be spotlighted, and we also have Spanish live interpretation if you click interpretation on the bottom of your screen. If you have questions that you would like the presenters to answer, you can go ahead and type them into the Q&A at any point, and then we will come back and answer those at the end of the session. Your video and audio should be automatically turned off. And so, like I said, use that Q&A to ask us anything that you want us to address. You will receive, I think it's on Monday, an email with a link to an evaluation survey, and you will have the opportunity to request a certificate of attendance on that survey. We also have CEUs for psychologists, and we will be putting into the chat how you can access and request those if you are a psychologist requesting CEU. You may hear about different research initiatives in some of these talks that are happening out of the University of Rochester. And a frequent question is how people can get involved. So if you are interested in getting involved in research, we do maintain a contact database, and you can click the link or access it with the QR code to sign up. We also have our resources related to this conference, as well as information from past conferences that you can access on our website. This is just a reminder for anybody who logged in a little bit later that you can access the Spanish interpretation by clicking interpretation on the bottom of your screen. Sorry, I think I am at the end of my housekeeping. I'm gonna go ahead and stop my share here. And with that, I would like to introduce our very first speaker. Our first speaker today is Dr. Kenneth Shamlian. He is a licensed clinical psychologist and assistant professor of pediatrics here in the Division of Developmental and Behavioral Pediatrics. In addition, he is a board certified behavior analyst and leads the outpatient behavior treatment program in our division. He will be giving a talk collaboratively with Patty Corbett-Dick, and they are both faculty of the Echo Autism series that has been enhancing community management of children and youth with autism for several years. Together, they have educated many clinicians about the co-occurrence of ADHD and autism, and I am excited to hear that today. Dr. Shamlian, if you want to go ahead and share your screen, I'll turn it over to you.
Great, thank you. This is such a pleasure to actually have an opportunity to talk to such a wide group of folks about this topic. It is one of my favorite topics. I would like to kind of just start off with saying that, you know, a couple disclosures here is that I'm going to be talking a lot about autism diagnosis in conjunction with like ADHD kind of diagnosis. And so We do take a strengths-based approach, but I apologize in advance that a lot of this language uses words like limitations, disorders, and that's just kind of the nature of really kind of diagnostic assessment. Secondly, I will be using terms like children and teens with autism, ASD, or ADHD. I will not not using identity first language, and it's just to kind of help discuss the materials today, which a lot of times don't yet use a lot of identity first language. And also there might be some mention of specific tools here in this presentation. They're not commercial endorsements. They're just some things that maybe we've used in our clinic. So I'm going to talk about ADHD and, and when it's present with autism, but actually, before we get into the specifics about assessment and management, I really just want to talk about marshmallows. Some of you may be familiar with an experiment from the 70s, the marshmallow test. The scenario kind of starts like this. There's children between the ages of 3 and 5, and they're taken to a room one by one, and they're tested individually. The test includes telling the child that the adults are going to leave for a few minutes. And if the child could resist eating a marshmallow, the one marshmallow on the table, until they returned, they could then have 2 marshmallows. Now, if the kid could not resist, eating the one marshmallow, they were told to ring a bell, and it would bring the researchers back into the room early. But they'd only be allowed to eat that one marshmallow because they didn't wait for the second one long enough. So if the researchers didn't hear the ringing of the bell, they simply came back after 15 minutes. There have been a lot of follow-up studies to this test, along with many opinions about the data and what it means. There's even one study widely published by faculty here at the University of Rochester not that long ago. However, a guy by the name of Phil Zalazzo and his colleagues at the University of Minnesota are quite well known for the work in this area. They did this same experiment, but with a twist. First, they had 3-year-olds sit at a small table with an adult, and the adult actually asked the kids to help them solve this problem, the adult's problem. They explained that the adult can have 1 candy to eat now, or if they wait until they're done playing games, the adult can get 4 candies to eat later. So what should the adult do? Most children told the adult they should wait and get more candy to eat later. These kids were pretty smart, so wise. However, when those same 3-year-olds were given the same choice, do you want candy to eat now or 4 candies to eat later, they usually chose 1 candy now. You might be asking why I'm talking about these marshmallows and these experiments, but these 2 experiments are really talking about a number of skills we refer to as executive function skills. And it just so happens that when we talk about executive function skills, we're actually describing some core skills in ADHD and autism that might be challenging for a child or teen. And while there's a range, most folks talk about maybe about 8 different skills underneath this umbrella term of executive function. And all these skills together is what helps us get things done. It helps us get things done in our social relationships and interactions, our work in school, and all the wonderful tasks of life. In the first experiment, we have these young children in a situation where they have to use quite a few of these skills. They had to keep the rules in mind. They actually had to remember those rules. They are regulating the emotional tension between the marshmallow in front of their face or waiting for more, and perhaps thinking about how they're going to wait and come up with a plan to resist. In other words, maybe coming up with a strategy for how they're going to cope and stay calm because they want this thing that's immediately available now, but they could have something more later. And maybe they're even checking their own behavior and whether the way that they are coping is actually working. So is what I'm doing working, or is there something that maybe I could do differently that would be better? So this was an experiment with marshmallows, but it was actually really so much more. And in the second experiment, it's the same thing, but there's an interesting twist, right? The 3-year-olds gave perfectly good advice to others, but they failed to follow that good advice for themselves. So giving the good advice to others is kind of like what we often refer to as maybe the cool executive function condition in their kind of twist on this marshmallow test. And so they could decide that for the adult. Not following that good advice themselves is kind of like what we would kind of maybe refer to as a hot executive function condition. They gave in to temptation. So these cold and cool executive function skills allow us to help us think more objectively about our own meaningful decisions. These skills can help us resist temptation for the sake of a more important goal. So why is this important? Knowing about hot and cool executive function skills can actually help us make sense of kind of like this phenomenon or these situations, right? Kids, adults, everyone needs a certain level of cool executive skills to weigh the adult's alternatives, more later versus less now, and choose to wait for that large reward. These kids in this situation, they could easily imagine that someone else will soon be happier with more. But when choosing for themselves, these children not only had to weigh the same information, more later versus now, but also actually had to resist the temptation, the impulse, the emotion of, I want this now, perhaps. And so this is too big a challenge for most 3-year-olds. And to be honest, though, you could think of lots of analogies, but it's probably maybe too big for a lot of adults too. But in summary, their hot executive skills can't handle it. They typically might opt for immediate gratification because they're having difficulties in all these other areas. When talking about ADHD, whether it's with autism or not, but today, since we're focusing on ADHD and autism, we can talk about it together. I really prefer to talk about executive function skills because it speaks more to the statements we hear from families about what their child and the family experiences altogether. Experiences that help describe the struggles with cool and hot executive function skill moments in the day. Experience that also help demonstrate how these skills impact the child and their family across their lifespan. And most importantly, they help explain like why in some situations the child or teen may do better in one moment, but not do well in another. And maybe it's related to the fact that in some situations, there's not some hot executive function skills, or there in some situations there are, where like it kind of, that's part of the problem. And there's other situations that might really rely on those cool executive function skills. And that's really maybe where they struggle. And so there's really kind of the same situation can maybe use different kinds of executive function skills. Even so, it's kind of hard to predict. So with that understanding, let's move on to more specifics about kind of ADHD and autism. In terms of where we're at it today related to understanding ADHD and autism together, we still have quite a bit to figure out, but we do know a few things. First, I have to say that the reasons why ADHD and autism may co-occur aren't exactly clear yet. We do know that the estimates across studies are kind of wide, but somewhere between 30 to 60% of kids with autism also have ADHD. And that also actually, that range kind of includes that preschool age as well. We also know that ADHD and autism do share specific factors, including genetic factors, which may be why some families have children with ADHD, autism, or both. There are some similar brain structure differences. It's more likely to occur in males, and similar challenges are experienced maybe by both with social interactions, executive function, and language delays. Oops. As our knowledge has grown, we also have actually changed our diagnostic understanding. It's actually hard to believe, but it's still less than 10 years ago since we realized or made the decision that kids with autism can have ADHD. And this is actually important because the change had very real world impact on treatment, especially with medication. So as of 2013, we can now diagnose ADHD and autism. They can co-occur. They're not one or the other. They can actually exist together mutually. And so now the clinicians are making decisions, in diagnostics about like your child's symptoms. Are they best understood as autism, ADHD? Is it both, or is it something else altogether? They share so many they share genetic differences. They share executive function differences. They actually also have lots of other overlap symptoms that are not included maybe in some of the diagnostic criteria for one or the other. In other words, for example, we might see sensory issues in ADHD quite frequently. So in summary, is it autism, ADHD, both, or something else? It's a lot to consider. A good deal of a clinician's job, and thinking about my job specifically too, is often explaining like what I call like the flavors that help differentiate between ADHD and autism, or maybe both. The descriptions of challenges socially or with restricted interest can look the same on paper and checklist ratings for any one particular child. But in a comprehensive evaluation with a trained professional, they can actually be quite different. And so understanding these differences helps us make this either or decision. It also helps with answering the both, or is it something else too kind of condition. What I want to emphasize is that things can look similar, but there are some differences. And when there are enough symptoms for perhaps ADHD as second diagnoses, second diagnosis over and above what would be expected for the autism diagnosis, we might consider it's not this or that, but both. And that can also be applied when it's flip-flop too. That is, like, if a child has a diagnosis of ADHD, it's if the symptoms for autism are over and above what would be expected for ADHD. It's challenging for all of us. It's challenging even for professionals who are really quite experienced. In the case of those who have both, though, I want us to appreciate that not only then do these individuals, these kids, these teens have these core differences for autism, but we're adding the understanding that there are additional challenges that we need to appreciate. For example, not only do they have to navigate the social rules of interactions, but in moments they also may have difficulty with regulating their attention in the interaction or resisting other kinds of impulses. And this can be so challenging, even when motivation is high for those social interactions as well. To go back to the basics, we have specific criteria for 3 different types of ADHD. And there are other kind of like options, diagnostically, like unspecified or other specified ADHD, but those are really kind of reserved for specific situations when we just need more information before we can get more specific to these 3 types. So in short, you could have this, you have this criteria for inattention, and it's kind of mostly related to attention regulation issues. I often think about this as like the symptoms of the dreamer or the absent-minded professor in terms of how we can think about what it might look like. You can also have a mostly hyperactivity or impulsivity kinds of symptoms. And unfortunately, this is kind of the symptoms that typically have created the stereotype for ADHD. These are the kids that we think about that the moment that they walk into the room, it seems that they've already climbed the wall. Perhaps they've already asked a million questions or who knows what, right? And unfortunately, it gives them a bad rap because many times, obviously, they're beautiful human beings, but sometimes they're doing things that seem more obviously socially unacceptable. Whereas our kids who might be more inattentive in symptoms might get overlooked. They're quiet. Maybe they're withdrawn. Maybe no one realizes that they're having difficulties because at the end of the day, they're not jumping around the room or they're not talking excessively. They might be kind of thinking about something else in a whole different world. Of course, you could have both. And so that's kind of like that combined type. And so we have a predominantly inattentive type, hyperactive impulsive type, or you have a combined type with both those. While these are the symptoms, there actually are other specific criteria that we're looking for when we think about diagnosing ADHD and autism. We have to think about it across multiple settings and people over the span of 6 months. It also has to affect, functioning in one or more areas of the child's life. And again, we need actually, even though I've listed all those 9 symptoms for maybe inattention or hyperactive and impulsive symptoms, you need only like 6 out of the 9 in any one of those areas, or maybe you could have 6 out of 9 in both those areas. And this kind of really helps, again, determine which type of ADHD gets diagnosed. And lastly, we know that these symptoms need to be present before age 12. However, because there is enough research to suggest that there's some improvement of ADHD symptoms, and it happens with age, that criteria gets lessened for older adolescents and adults, and maybe there's only 5 symptoms that need to be present in any one of those categories or both. And as a small caveat, I would like to kind of mention too that while it doesn't say this in the diagnostic manuals, we do some, it's not unusual for us to see signs of ADHD well before the child is actually 4 years old. But when they are 4 years old, if we've been continuing to kind of watch them and they're still present, and we don't have any other better way to explain it, we do diagnose sometimes ADHD at age 4 years as well. And that kind of comes from also some guidance from the American Academy of Pediatrics. So we have all this criteria, but the thing is I like to always kind of tell others, it's so much more about the big picture. And a good clinician is also going to be thinking about how these symptoms for this criteria that they have to meet actually also matches up with what you've got from like other kinds of sources of information. And they're going to be thinking about even those patterns of executive function deficits. Those are also going to be very important to them. We do have some best practice kind of ideas for identifying ADHD and autism. Obviously, screening and evaluating ages 4 to 18, if they're showing any symptoms of ADHD, would be important. In addition to that, we have this kind of long-standing tradition, which is good clinical practice, to make sure that we're getting information from multiple sources in people. This might start off with using the rating forms and other kinds of information or screening tools. And for example, this might include like the Vanderbilt scales, which are typically used in pediatricians' offices, and these can kind of be given to parents, teachers, and daycare staff. However, the criteria for diagnosis is really best assessed when we include things like clinical interviews with the parents and caregiver, maybe an interview with the child, depending on their ability, and really direct observation. So we're using these opportunities in addition to like things like rating forms and maybe standardized tests to understand the duration of symptoms, severity of symptoms, and also even at that point, still screening for other symptoms. Remember, we actually have this issue of, is it ADHD and autism together? Is it one or the other, or is it also maybe something other else, right? And so we might be screening for things like anxiety, maybe some oppositional kinds of behaviors and challenges that are common to children with ADHD, especially if it's present within autism. And of course, we often are making sure that it's important for us to not skip those issues that we can't ignore, things like depression or suicidality or other kinds of mental health concerns. So we're taking a holistic view of how we need to understand the child and your child in the family. And again, I want to maybe reemphasize one more time that this process, we really want to consider an additional ADHD diagnosis when we see symptoms that are not better explained by a diagnosis that's already existing, whether it's autism or something else. In all cases, we recognize that it really takes the village, right? It takes the school, it takes the medical team, the family, and everyone to not just maybe do the diagnostic part, but also kind of getting supports in place the best that we can. In young children, we try to optimize home and school supports, especially any therapy that will help families and the child with skill development. Again, executive function skills are skills that can be learned and can respond to intervention and support. And behavioral types of therapy are considered to be the most effective. This can include focus specifically on things like coping skills and problem solving, maybe executive function skill building across the board, or replacement skills such as teaching what to say, when, where, how, etc. And of course, this can also include managing those episodes or learning how to manage those episodes where behavior is really quite challenging to support. I will say that for older children, the research does suggest medication and therapeutic support are actually likely more effective. And so there is maybe an increased attention to consideration of medication as the child gets older. When it comes to optimizing school supports for children with ADHD and autism, especially if ADHD is added to autism as a little bit new part of the diagnostic picture, it might mean that requesting additional evaluations or meeting with school teams is necessary. It's necessary to determine what else needs to be assessed. For example, could they help assess again with like the ADHD symptoms and help provide observations to help with the diagnostic process, or can they help with monitoring whether the supports for ADHD, especially its executive function skills, are actually working? And so as they go through this assessment, or as we're thinking about that question, it might lead to us maybe understanding what supports still need to be added in to the specific plans that maybe they already have. Some of those are like the IEP for ages 3 to 21, a specific family service plan if they're in this kind of like birth to age 3, which again, we don't diagnose ADHD at that point. However, we can still see sometimes symptoms that would be warranted and still make sense to kind of support. And, or is it also that we need to maybe adjust a 504 plan or just some of these accommodations in the school setting so that they can actually do the things that are required of them with their academics and the school day. And another thing I would also just kind of like to kind of mention here in terms of like parent advocacy is that, you know, one thing that we do know is that raising concerns obviously are your right as a parent. You actually have parent rights that are protected, but parents using their voice to ask questions and be part of this process can really help to set the stage for working out a plan for their child. So it's okay to be a squeaky wheel. You're a parent, this is your child. And I think, you know, making sure that you can do your best to kind of feel like you're supported and advocate for your child is really important as you notice these differences. And that applies just outside of school into any other kind of domain as well. Lastly, I think I would like to kind of go over just some treatment considerations. We already know that behavioral interventions and supports are probably the most effective. And there are specific therapies that really do address this, right? So behavioral therapies or even applied behavior analysis kind of therapies can really kind of help target some of these core executive function areas and maybe behavior management difficulties. And maybe for older kids, things like cognitive behavioral therapy approaches are really effective as well. But there's also just some basics. And I really want us to think about many of the interventions and supports for ADHD within autism as kind of like prosthetics, like glasses or hearing aids. Our kids with executive function skills that are delayed need these things to be successful. They need them day to day. They might need them long term. And if they're lost along the way, they need to be replaced. And so thinking about them as glasses or hearing aids actually is probably pretty appropriate. So we all have executive function skills to one degree or another. Some of us are maybe better with them. Some of us maybe struggle more. And so we also use all sorts of things, right, to help keep us organized or regulated or paying attention and so on and so forth. We keep our things documented in our calendars, our phones, so that we can remember when things are due, when appointments are, and things are like that so much. Because we can't keep everything maybe in our minds, right? We can't keep everything at the forefront of where we need it to be so that we can make sure it gets done. And I think our kids are the same. So in the same way that I don't recommend sending your child out the front door without their glasses, I also don't recommend sending kids out the door without supports and plans for executive function and any other skills that they need until it's mastered. And so this is a developmental process, and we need to make sure that we're putting things in place, and we can't just skip it. So if we're sending our child out of the house and we want to support them, we can think about what might be helpful to make them successful. Obviously, there's the more intensive kind of therapeutic supports, which are very appropriate and have shown great success in many cases. But in engineering success, we should also be thinking about how we can just generally set them up, right? What can we do to help them understand the expectations, remember the rules when things need to get done, and maybe when something is or is not available, using concrete ways that help them get over some difficulties that they have with executive function is one way to do it. So if they're having difficulty with those hot executive function skills like waiting, can we show them a visual timer, right? That maybe helps them predict how long they might need to kind of keep it together or when something's going to happen, right? If there are situations that they can't tune out distractions, maybe they need some noise canceling headphones. If they can't remember when things are supposed to get done or what choices I need to make and when, maybe they need a visual roadmap of some sort to kind of keep them on track for getting it all done when they need to get it done. It also can include things like using other types of technology like apps or simple calendars. more basic things like checklists on the walls of the front door or the bathroom so that they know all the routines that they need to do and remind themselves like, oh yeah, I need to do that. Thinking about the tools we could get them to help break down the steps and give the structure that they need could be important for day to day. We may also need to think about maybe even incentivizing or creating motivation to use these tools, because sometimes kids don't want to slow down enough to do it. So we might need to kind of find ways to help them say like, oh, I think it's worth it to me because mom and dad are helping set up the situation where maybe I do get a reward if I can actually use these tools to get through all the things that they've asked me to do or expect me to do anyways. And for older older children or children with maybe language skills that this would be appropriate for, checklists, strategies like goal setting or behavior contracts and other tools to help them kind of take charge of what needs to be done through self-monitoring also might be things that would be appropriate. Finally, I really just want to kind of mention that there might be some pearls to hold on to here. Like I said, executive function skills are really that. They are skills that can be developed. And that can be true whether you have executive function skills and you don't have any diagnosis, that in your executive function skills are somewhat delayed, or they're just kind of showing some splintered kind of performance deficits. In addition to that, you could have executive function skill deficits, again, with ADHD and autism, or just ADHD or just autism. But in the specific case of ADHD and autism, it's just as applicable that we can work on these things early on, and we can extend that practice throughout the lifespan, even up until adolescence. And it doesn't have to be all lecturing, and it doesn't have to be all at the table. There's many ways to start promoting self-control and regulating attention and many of these other executive function skills, so that we can definitely start building it. Think of it as flexing a muscle and kind of working out a muscle. It takes time. It might take you 3 months to get to a point where you start to really notice some difference. So I always like to give the examples of Simon Says and red light, green light, for kind of like helping kids learn through play of listening to the rules, paying attention, not acting on autopilot, right? And so there are ways to include this. I do have a resource here that gives lots of ideas for maybe how to include this from infancy all the way to adolescence. I also like to remind us here that for many of our kids who struggle with executive function skills, the world can be a bit of a punishing place, right? They're always kind of getting a message of, don't do this, you're doing this too much, you're not doing this enough. And so really we want to kind of do our best to kind of straighten out that ratio, balance it a little bit more. Catch them being good whenever possible is so key for your relationship with your child, the key for the message that they're also doing things that are good. They're not just doing things that might be problematic or things that they feel like they might be failing at because they're just not meeting the expectation. They're developing a little bit differently, a little bit slower. And so they still need support. And very lastly, be the executive function guru that you want your child to be. So maybe this is an opportunity for us to continue to think about our kids who struggle with this and they have ADHD and autism. And what are some ways that maybe we struggle with it too? And are there some things that we could be doing as parents that might model this a little bit better? And we're doing it as often as possible. I think that might be also just general wisdom, but certainly in this case, since this is a kind of like a core area where these deficits might exist or limitations exist, and they're on their way to developing these skills, what are some things that we can identify in ourselves that helps us figure out what might work for them and what can we do to model that for them? And with that being said, thank you so much for this opportunity to talk about this topic. I love it. And thanks for letting me have the opportunity to talk with you a lot about marshmallows.
All right, thank you. So I think the executive functions that we heard about are so critical for multiple aspects of people's lives. In particular, the distinction between developing cool skills and being able to use them in the moment is a challenge to which I think we can all relate. And so understanding the overlap between autism and ADHD is really important for treatment, as you highlighted. And next, we will be hearing a little bit more about medical treatment implications for ADHD and autism. And so with that, I'd like to introduce Patricia Corbett-Dick. She's a faculty member in the School of Nursing. She's involved in educating graduate students, both as a psychiatric and pediatric nurse practitioner. And she is an expert in psychopharmacology. And with Dr. Shamlian is a faculty member for the University of Rochester ECHO series, which helps with education of medical providers in our community. And we are honored to have her educate us all today. I'll turn it over to you, Patty.
Thanks so much, Dr. Knight. I'm just going to set up my screen share here.
Do you also want to turn on your camera? Or?
Sure.
Okay.
How are we doing? Can we see my screen?
I cannot.
Okay, let me go again. Thank you for... Okay, how are we doing now?
That looks good.
Okay, you can see my screen. Okay, except I'm on the wrong slide here. So we'll just get back to the beginning. All right, thank you very much, Dr. Knight. It's a pleasure to be here, and it's always a pleasure to present with Dr. Shamlian. And I'm so appreciative to be part of the Skirboll conference, and thanks to the Skirboll family as well. I have no financial disclosures and no associations with pharmaceutical companies. There will be some discussion of psychotropic medications, both the ones that are FDA approved for children and also the ones who have off-label uses. Our learning objectives today, I hope to cover the best practices associated with assessment and treatment of ADHD in individuals with autism. I'd like to describe shared decision-making as a very useful and powerful model to guide selection of interventions for clinicians and families to work together. We'll be identifying the common ADHD medicines that are used to address hyperactivity, inattention, and impulsivity. And it's very important to me to share resources because it will take all of us, it takes the village to care for children with complex and special health care needs. So Dr. Shamlian set things up just great for me because he covers so much. It allows me to just take off and talk more about the medical end of things. But I can't do that without first saying that educational and behavioral interventions remain the mainstay of intervention in autism. So no matter what the co-occurring condition is, if autism is the umbrella diagnosis, educational and behavioral interventions for that diagnosis continue to be needed. Medication. There is currently no medication to target or treat the core features of autism, which we know relate to social communication and restricted and repetitive patterns of behavior. Challenging behavior concerns are common in autism, but we should, as Dr. Shamlian said, assess and treat for common medical issues as well as co-occurring diagnoses, which are common, and including ADHD, anxiety, and mood. And I think it's important to point out that these both are considered clinical diagnoses that require the complex gathering of comprehensive medical and behavioral symptom data. Having each diagnosis specifically will guide the best treatment for each one. And so, unfortunately, at the present time, there's no one clinical test that objectively says whether someone has ADHD or autism or both. So there's no, while they're in research, there are MRIs and brain scans and things. And right now we have clinical diagnoses, and that's why it requires this comprehensive and often multidisciplinary care to do comprehensive work. What do we know about our evidence base? The research trial data regarding ADHD treatments in children without ASD is more robust than it is in children with ASD. So we know more research is needed about best treatments, medication safety, long and short-term efficacy, tolerability, and outcomes in youth with autism and ADHD. And that's why we're having a great conference today. And we'll hear more from Dr. Hyman and Lynn Cole about those initiatives. So even though we don't have a huge research trial base of information about ADHD in autism and medications with excellent randomized large trials, we do have guidelines that help us do important patient-centered best practice using our professional organizations to help us have standards of care, improve our clinical decision-making, and focus on the best patient outcomes. So we definitely need more research, but these clinical guidelines coming from, I listed 3 important ones here, the ADHD practice guideline that comes from the American Academy of Pediatrics, the Autism Clinical Report, our own Dr. Hyman led that charge from the American Academy of Pediatrics. And then finally, the Society for Developmental and Behavioral Pediatrics has put forth a guideline for assessing and treating children with complex ADHD, with autism and other comorbidities, including ADHD. So we look to these, we look to expert opinion, and we look to the study of typically developing children with autism, and what we learn about medications from those good studies help inform our careful care of the children with autism and ADHD. Dr. Shamlian talked about the careful educational and behavioral assessments. It is important as we think about medication or biobehavioral treatments to think about what are the common medical comorbidities that are seen in youth with autism. This is a high priority because some of these will affect whether a particular medication will be useful or whether it won't be tolerated or whether there's a treatable medical condition that should be dealt with before treating behavioral symptoms with medication. So we think of these common medical comorbidities as the genetic considerations, gastrointestinal symptoms, well-known feeding, sleep, and constipation concerns, as well as seizures. So these conditions would need to be assessed in the child with autism before considering other comorbid diagnoses that would be in the behavioral health realm. So as with anything, when we do think about medication interventions, we need a complete medical history. And for the children we are thinking about medication for ADHD, we want to think about a good complete physical exam, hearing and vision, looking at their growth, their nutrition and diet, and any other treatments, medications, supplements, or over-the-counter products that they might be using at this time. From a family medical perspective, as Dr. Shamley mentioned, the genetics and things that run in families, both autism and ADHD tend to be highly heritable. And so assessing for the presence of these other conditions in family members can really help us narrow down sometimes diagnoses and treatments that would be relevant. It's very helpful also to know, and this is something families can maybe think about or talk about sharing, if there are mental health or behavioral health conditions in other family members. Are there medications that were helpful or caused bothersome side effects in other family members? Because some of the metabolic pathways that break down and metabolize medicine in the body can be associated with genetics. So those can be really informative. And these are complex and co-occurring conditions. So that's why this really complete approach is required to do this responsibly. Dr. Shamlian talked a lot about the behavioral information that would be required, and I echo his point that we want to focus on strengths, positive attributes, and a child's interests. And I think it's clinically very relevant to find out when do the challenging behaviors not occur, because that can give us more information too. And yes, it can be collected on, our rating scales that are used, but I think this is an important piece of an interview to highlight the child's strengths and successes as well as these challenges. Early behavioral presentation, temperament, and any early adversity, months in the NICU, things like that are important to know in terms of informing behavioral information. And then, as we've talked about, the hyperactivity, impulsivity, inattention, and other behavioral concerns that might include aggression or other comorbidities like anxiety or depression. And Dr. Shamlian talked about the importance of the academic history and the academic setting in meeting the child's needs. And also understanding about the family context is important before prescribing. Insurance, resources, who lives at home, what are the stressors, what's the parenting style, culture, ethnicity, both inform at times views and experiences of medications or treatments. And then it's really important when we think about children's behavior to think about any exposures to traumatic or violent situations or displacement, because those will often be demonstrated in challenging behaviors. So we need to consider, have educational and behavioral interventions been mobilized? Is the child stable? Are there persistent impairments and risks, for instance, to safety, to community engagement, to the family and school and peer relationships? And are these of sufficient intensity to warrant medication treatment? Are there associated conditions or symptoms for which there is an evidence-based treatment? Because not all behaviors have a medication that would be targeting reduction in them. What are the child and family factors? And does the household and the family context support safe medication use and side effect monitoring? Considering the quality of life, the amount of distress that the child or family are experiencing, a goal in treatment would be reducing symptoms and ensuring that services that are valued and useful for the child are preserved, and really promoting those functional outcomes and addressing the potential benefits of treatment against any loss of further delays in skills without treatment. We want to engage in help children engage in therapies to the degree that they're able. So it's complex. We don't have enough evidence, and sometimes shared decision-making is a really useful model, well suited to the complex diagnoses of ADHD and autism. And this is a model that's important when research evidence is less clear. And the goal is to balance patient values, family values, and preferences with risks and expected outcomes. And psychotropic medication is certainly, use in children is certainly a great example of a great place to apply shared decision-making. Out of our division has come a decision aid for guiding toolkits for guiding families and clinicians around helping make this decision, which is often challenging. And the key points that we can see in that decision aid is information about medication, whether it's the right time to choose it, and understanding that there are no medications that will eliminate all challenging behavior. They may reduce specific challenging behaviors to a degree. There are always potential side effects, and a good relationship among the clinician and family and patient are essential. Some medicines are FDA approved for children and some are used off-label. None are approved for the core symptoms of autism, so that's important to keep in mind. There are rarely medicines that are used as needed, and it's important to start only one new agent at a time to have an adequate trial. So those are some of the things and other treatments that had been tried. Is there a readiness in the family to initiate medication? And do the supports and resources allow for that? Or is it a time to intensify other treatments, educational or behavioral, or family or home-based treatments? So we need to pick a target behavior when we are thinking about medication. So on the left here, ADHD, anxiety, sleep, or irritability, they may be target behaviors that we would consider medication useful potentially in reducing. There are some behaviors that are not going to improve with medicine. So that sense of children who are a bit more oppositional, those behaviors tend not to be helped as much with medication. Refusing behaviors like flopping or running, slow learning is not improved with medication, and communication skills aren't improved with medication. So it's important to have realistic expectations. Some target behaviors that might be very useful are the ADHD to be considered for medication, sleep onset, anxiety, and irritability, because those all have a more significant research base. The toolkits include nice charts like this. So this can be really useful for understanding these medicines, which are very complicated in many ways. Their names are complicated, their formulations, brand and generic. So on the left column here, we have the different types of medicines that might be used in ADHD, the stimulants, and then the lower two rows are non-stimulants. The target behaviors are listed, mostly associated with the hyperactivity, impulsivity, and inattention. Some may be more helpful for sleep. Some may have side effects that would affect sleep negatively. So those are common things that we would want to consider with a family and looking at the individual child. And side effects are a reality. So knowing which side effects go with which medicines. And so a reference like this, or there's another reference that I've provided at the end of the slides, Children and Adults with Hyperactivity and Attention Deficit Disorder, as an organization called CHAD, and they have a really nice medicine chart that's very detailed about each product, and including, I think there are approximately 30 formulations of stimulant medications at this time. So it's kept up to date, and I find it really useful. So that's on our reference list. The other useful toolkit to walk clinicians and parents both through tackling some of the biggest concerns, side effects, how to manage them, how to evaluate or track the target symptoms, how to think about palatability in children with autism. Obviously, pill swallowing, taste, texture, preparation all matter. And so it's not a one, let me write one prescription and then we're all set. These are all things that need to be considered for an effective trial and for safe and careful prescription. So what do we know about starting ADHD medicine in kids with autism? It would, unless contraindicated, and that could be a medical condition, youth or family preferences, it makes sense to generally start with a stimulant, and the methylphenidate products, the things that have Ritalin in the name, tend to be better tolerated than the Adderall in children. And while Adderall in adults is seen as more robust, the tolerability tends to be lower for children, but it doesn't mean it's not used or can't be used. Some children will do well with one and not with the other. Overall, though, with stimulants, there's a lower response rate than in children with autism. Sleep and appetite are the big concerns. We want to start low, pick a target dose, do one medicine at a time. it's important to consider a trial off it. Usually that just happens because people forget to give a medicine and they notice either the child's better or worse off it. And so that's important information. When we have co-occurring conditions, it's important to think a little bit differently. Sometimes ADHD in a typically developing kid the coverage of, school day might be adequate, but in a child who has autism and ADHD, it may be beneficial to think about longer coverage, but that would be individual assessment and planning. A second agent for evening hours or sleep onset at times might be required. We want to use the least amount of medicine and a single agent when possible, but sometimes we are in the position of supporting families and children, both with ADHD medicine during the day and to cover the evening too. So close follow-up is always important for an effective trial. So stimulants. Here's our list of stimulants. What do they do? Stimulants act on two neurotransmitters, dopamine and norepinephrine. It's not as simple as that. There are many different actions, but those are typically the two neurotransmitters with the most significant action from the use of stimulants. These are chemical messengers and they send information between neurons in the brain. This communication is important in attention, focus, concentration, impulse control, and risky behavior. And there are no other mental health medications with as high as a response rate as stimulants. The effects are seen promptly. And we have been using them in children for many, many years, 50 years, I think, for Ritalin. And so that does give us a long period of experience with it. They have challenges with tolerability for some children, and sometimes the sleep and appetite side effects are intolerable, but lots of the sleep and appetite effects can be moderated with the right timing, the right dose, and the right care through the day in terms of appetite management. So stimulants are first line. They come in multiple formulations. The duration of action is 3 to 12 hours. They're thought to stabilize levels of dopamine and norepinephrine. And a comment on preschoolers is, as Dr. Shamlian mentioned, 4 years old is sort of the cutoff where we feel more comfortable giving the diagnosis. But in this age group, behavioral treatment is always advocated as first line. And then if medication is required, methylphenidate is better tolerated than Adderall. It definitely has a higher side effect profile in this age group, and it may be important to consider non-stimulants. But this is an area that we need more research, right? These little kids and the kids with comorbidities. Non-stimulant medicines include atomoxetine. It's considered a selective norepinephrine reuptake inhibitor. Again, one of its actions is norepinephrine. It has other actions in the body. It's considered second line, but it can be used for folks that can't take stimulants or where it's a preference to not use them. There is a brand and generic formulation that comes in a capsule. It tends not to taste delightful, so that can be a challenge at times, but there are lots of strategies for kind of workarounds for that. It's FDA approved for 6 and up, and it is thought to last 24 hours. Dr. Hyman led us in a clinical trial in 2015. It finished up. And in the study, it was noted that there was decreased appetite as a side effect, but better tolerability than with stimulants. And it's thought that atomoxetine may have a better effect on inattention than hyperactivity or impulsivity, and potentially some benefit to anxiety symptoms. And up to 40% of children with autism and ADHD show some improvement. It's slower to start working. It's slower to start working. It's not immediate like a stimulant. So there are differences and less effect on sleep. Another group of non-stimulant medicines are what we call alpha agonists. And the brand names for those are 10X and Intuniv for the guanfacine. Clonidine is Catapres and Capve. They target hyperactivity, attention span, impulsive behaviors, and sometimes they can help with sleep problems because they have sedation as a side effect. So important to have sort of a picture of the child through the day as we tailor the medication choices. They're both available in short and long-acting forms. The long-acting forms are FDA approved for children 6 and up. They're considered second-line medicines, but again, for kids who can't take stimulants, they can be used as single agents or can be used in combination with a stimulant. They may be useful after school, where a stimulant might be useful during the day, and then as that wears off, adding in an afternoon non-stimulant like an alpha agonist can be useful. But again, these would be individualized decisions. It's thought to be useful off-label. That means it doesn't have a specific indication for any children for outbursts, aggression, and sleep onset. Let's see, the long-acting guanfacine is a swallow tab, which is a barrier for some children, but children can learn to swallow pills. The short-acting tab can be crushed, and the long-acting clonidine capsule can be opened. And this seems to have effect on both norepinephrine and dopamine as well. So in summary, medicines can be useful in addressing impairing ADHD symptoms in youth with autism in combination with educational and behavioral interventions that are the mainstay of treatment. Decisions should be made about medication in partnership with youth and families, considering preferences, beliefs, and goals, as well as risks, benefits, and side effects. There are medical considerations, and keeping that in mind and balancing optimal engagement in family, school, and community are our treatment goals. Collaboration among our school providers, medical providers, community providers, and families will kind of make that team around the child who's taking medicine and optimizes the opportunity for safe monitoring and careful evaluation of the benefits or the adverse effects. There are multiple valuable resources available, and I would encourage folks to look at those, and I have those on our slides, which I believe will be available. And since we do lack, really huge studies with great evidence in children with autism and ADHD, it's important for us all to inform ourselves about the best and safest practices. And I encourage school professionals, parents, community providers who might be here today to spend some time looking at the resources and maybe having them available in your offices, your spaces, to share with families. It's a great work. Some of them are great working tools for the decision making. So thank you for your attention today, but let's remember that we need more research to really further identify the safest, most effective treatments for youth with autism and co-occurring conditions. Thanks so much. And there will be some resources available on the slides. Thank you.
All right, thank you. These are common questions we talk about in clinic, and we know effective treatment makes a tremendous difference for people. So I think it's helpful for us to have a shared framework and some guidance when we're deciding how or when to safely and effectively use medication. As Patty noted, though we have our current best practices, we would also benefit from more evidence for how to treat autism and ADHD most effectively. And so next we have Lynn Cole, who will talk with us about how we are taking some of those next steps. Dr. Lynn Cole is a faculty member in the School of Nursing and Pediatrics, and she is the Associate Division Chief of Developmental and Behavioral Pediatrics and the Director of Clinical Services. Dr. Cole is a leader in quality improvement efforts of the Autism Cares Network, which is a consortium of autism and developmental pediatrics programs across the US and Canada. And today she'll be introducing us to how this work impacts care here in Rochester. Thank you, Lynn. Lynn, you're muted.
Sorry, it took me a moment to find my unmute button. So thank you, everybody. Today we will be talking, I'm happy to be here to talk with you about kind of the next step. So going from what we know about medicines in children with ADHD and autism to how we can figure out what might be the best approach to treatment. So I have no disclosures. So let's review a little bit what we heard from both Patty and Ken. So what do we know about ADHD and kids with autism? So we know that lots of kids with autism struggle with ADHD symptoms. We know that hyperactivity and impulsivity can really lead to some significant safety problems. And that hyperactivity and inattention can make learning really hard. It's really hard to sit still and learn in your first grade classroom if you really can't stay in the chair and you can't pay attention. We know that behavioral treatments can be helpful, but they're often not enough. And that we know that ADHD medicines work well in kids with ADHD without autism. So let's think about what do we know about autism and ADHD and medicine. So what do we know about specifically the efficacy and the side effects of use of medications in kids with autism? So in this slide, I've kind of summarized the different groups of medicine and talked a little bit about what research do we have. So in the area of looking at methylphenidate, which is the usually the first line treatment for children with ADHD in general, there's really just 4 studies looking at kids with autism and ADHD. Each of those studies only lasted between 1 and 2 weeks, and people who've reviewed the evidence and kind of pulled all of the evidence together has said the evidence is kind of low to very low quality. So we've got some evidence, but it's not great. What that evidence shows is that this medicine is definitely associated with a reduction in hyperactivity, and depending on the measure you use, perhaps some improvements in inattention. We really don't have any good studies on the use of Adderall or amphetamine in children with autism and ADHD. Similar to methylphenidate, Strattera or atomoxetine has been studied in kids with autism and ADHD. There's about 4 studies. These were a bit longer, partially because atomoxetine takes longer to start working. So these studies were each in the range of 6 to 10 weeks long. They showed some improvements in hyperactivity and in inattention. But again, the evidence has been judged to be kind of not great quality. There's only been 1 study looking at the use of guanfacine, so one of those alpha adrenergic agonists, in children with autism. That study was about 8 weeks long. It showed less hyperactivity, but again, the evidence was not super high quality. And then finally, there have been a number of relatively high quality studies looking at the use of atypical antipsychotics. So that's things like Risperdal and Abilify in children with autism. These studies were really designed to look at the target symptom of irritability, so things like aggression and tantrums and self-injury. But they also measured hyperactivity and showed that atypical antipsychotics are associated with a reduction in hyperactivity. But these are much higher side effect medicines and not something we usually think of as a primary treatment for ADHD symptoms. So I'm going to just kind of take those ones off the table for today. So what's a clinician to do? Like, we talk about this all the time in our clinic, is given this limitation in evidence, like, how are we really supposed to advise families? How do we know what medicine to choose first? How do we know what dose to start at? How do we know when to give up on the first medicine and move on to the second medicine? So advising families around treatment of ADHD and autism is really very challenging. And we're often left to rely on guidelines and research on children with ADHD in the absence of autism, which is better than nothing, but it's not really the best. It's not really the best guidance for how we want to be treating our children with autism. So here comes in something called PCORI. So PCORI stands for the Patient-Centered Outcomes Research Institute. So this is an independent nonprofit organization focused on research. It was authorized by Congress in 2010 and reauthorized in 2019. And something that was really notable in the 2019 reauthorization is that one of the research priorities that was added was the study of treatments for people with intellectual and developmental disabilities. So PCORI really has a big focus on outcomes that matter to patients, and it really aims to be able to empower patients with what they call actionable information about their health and healthcare choices. So PCORI really focuses on having patients and families, especially when those patients are children, at the table throughout the research process. The focus of PCORI, or the main type of research that PCORI funds, is something called comparative clinical effective research. So this is a type of research in which there are multiple treatment options, and it's really comparing one against the other. So for our purposes, this might be different medications for treatment of ADHD. In other situations, it might be a type of service or a type of health practice. And really the reason that comparative clinical effective research is so important to PCORI and why it's mostly funded is because it helps patients and families to know whether some approaches work better than others. And it helps patients and their caregivers and their families to be able to make better informed decisions about their healthcare. So the Autism Care Network, which Emily mentioned at the beginning of this session, is a network of autism, university-based autism care sites across the US and Canada, started developing a proposal. So this proposal, we really started working on this in 2020, submitted it in 2021, and we found out in the spring of 2022 that this award had been granted to this network of providers. We've spent really most of all of the summer and into the fall refining some of the details on this, working with PCORI to make sure it lines up with their goals and objectives. And we're aiming to launch soon, like any moment. And so I'm going to tell you a little bit about the type of trial that this is that we're going to be running. So we're running what's going to be called, or what is called, a pragmatic trial. And so a pragmatic trial is when you test the effectiveness of an intervention in real world settings with real world typical patients and qualified clinicians, but those clinicians may not necessarily be researchers. So this is different than a lot of the typical drug trials that are conducted in a very controlled setting with very limited patients who are very, maybe don't have a lot of comorbidities or in a very narrow age range. And the reason that a pragmatic trial is important is that what we find in some of these very controlled clinical effectiveness trials is that the findings from that don't often transfer to real world settings. And we really want to know what happens in everyday practice. So for this trial, 12 of the sites from the Autism Care Network will be participating. So you can see these are some sites out in the West, some sites up in Canada, some Midwest sites, and then some East Coast sites. So we're the Rochester site. And this pragmatic clinical trial has been developed with the idea that it should really follow our normal clinical practice. So what we're normally doing in everyday settings right now. There's 4 aims of the study. The first is to determine whether one type of stimulant medicine is more effective than the other. So helping us answer that basic question of when we're starting medicine in a child with autism and ADHD, should we start with Ritalin or Adderall? So that's the first basic question. Beyond that, the second aim is that when that first attempt at using a medicine isn't effective, that first medicine doesn't work for that child, should the second medicine be the other stimulant, or should it be an alpha agonist? So something like guanfacine or clonidine. We also want to identify how parents make decisions about continuing or not continuing medicines, because really, like, my assessment of effectiveness in clinic doesn't matter that much. It's really families' experience of how the medicine impacts their child that's most important. And finally, we want to look at what we call moderators of treatment response. So are there things that make a child more likely to respond to one medicine than the other, more likely to have side effects, more likely to respond to a lower dose or a higher dose? So we'll look at things like age and gender, and do they have other diagnoses, or is their developmental level different? So potential participants for this trial include really children between the ages of 4 and 17 who have confirmed diagnoses of ADHD and autism. We're going to be looking for kids who are able to tolerate taking medicines and who have a parent or caregiver who spends a lot of time with the child and who can report on the effectiveness. And these, because we really want real life patients who are experiencing the regular things that we see in kids with autism, other medications will be permitted as long as that medicine is stable and we don't anticipate a change during the study period. So if a child is already being treated for anxiety, that child can continue their anxiety medicines. If they're being treated for seizures, they can continue that seizure treatment. Really, the only exclusion criteria are that this child has already tried multiple medicines for ADHD. So we really want kids who are more early in their attempts at treating ADHD. They need to be at least 4 weeks out from the time that last ADHD medicine was used. And then just that there's not any other risk factors from like having them be able to safely take medication. The treatment, so this will be a 16-week trial. So there's 2 phases, 8 weeks and 8 weeks. So basically the child will be enrolled and consented. And the only time there's what we call a randomization. So the only time where the family and clinician aren't going to choose which medicine to start is the initial point. So when the child is consented, they'll be entered into kind of this randomization, like where you get a random number. And we will, based on that, either start the child on a methylphenidate product or an Adderall or amphetamine product. Whether that's short acting or long acting and how it's titrated and how it's dosed will really be based on normal clinical practice. From there, the child will generally stay on that medicine, although the dose might be adjusted for 8 weeks unless they have side effects. And during that time, we'll collect parent assessments of response. At the 8-week time point, based on that parent assessment of response, we'll decide to either continue that medicine, like it's going well, no need to change, or we'll decide that the child needs to change. And that's usually because either it hasn't been effective or the child's having side effects. And at that point, the child will change to either a different stimulant medicine or to an alpha adrenergic agonist. And that will really be based on normal clinical practice, what the patient and family perceive would be the next best choice in combination with the child's clinician. In Rochester, we are aiming to start recruitment in sometime spring of 2023. It little depends on when the funding actually starts. We'll be recruiting about 12 patients a year for 5 years. So this is a long study. We'll be identifying patients through normal clinic visits. So when kids come in and are newly diagnosed with ADHD and we're talking about treatment, they might be identified there. But we'll also be letting families know about the opportunity to be part of this study through our division research registry. So this is just a little plug that if you're interested in something like this, join our research registry. We'll also share information through places like our webpage and our social media. So if you want to make sure to hear about this, you could also join our DBP Facebook page. And this is our most of our study team. So I'm the primary investigator. 2 of our nurse practitioners will be working on this since they see lots of kids with ADHD and autism. And that's Melissa Ryan and Joanna Stump. We have a new study coordinator. Her name is Emily Wagner, and unfortunately, I forgot to grab a picture of her before she went on vacation last week. And Claudia Perez, our Autism Care Network study coordinator, will be helping us out with this because she has lots of skills in this area. If you have questions or want more information about this study, this is the contact information for our study coordinator, and we'll always be happy to talk with families about it, although we won't be able to enroll until later this spring. So thank you for learning more about this up and coming research in our division.
Thank you. I'm excited that we're going to be involved in this. All right, so with this past 3 talks, we've talked a lot about the intersection of biology and behavior in ADHD. We heard about how important behavioral interventions are, as well as some of the evidence we have for medications in children with ADHD, especially without autism. And now Lynn, of course, has shared some of the exciting ways that we can expand this evidence to children with both ADHD and autism. These biology and behavior interactions are also important in our screening and our diagnosis of autism spectrum disorder. And so to speak to that topic, I am pleased to introduce our final speaker today, Dr. Susan Hyman. Dr. Hyman is a professor of pediatrics in the Division of Developmental and Behavioral Pediatrics. She recently stepped down as division chief, and we are all grateful for her leadership, and I am personally grateful for her mentorship. She and Dr. Cole have collaborated for years on Echo Autism and the Autism Cares Network activities that focused on setting the standard for diagnosis and care of children and youth with autism spectrum disorder in primary care and in specialty settings. And as I mentioned today, she will discuss screening for autism.
So thank you very much. And thank you all for hanging in there through this beautiful Saturday morning. As you heard from Ken, Patty, and Lynn, part of the reason for follow-up after initial diagnosis is to screen for things like ADHD, but key is identifying autism in the first place. And what we'll be talking about this morning is screening for autism. I have spoken a bit as a consultant for other organizations. I want to let you all know that I am a consultant for the Baby Navigator program that we'll be talking about, and have had other funding. So this morning in the last talk, before we get to your questions, we're going to talk about why we screen for autism, who we screen for autism, when we screen for autism, and how we screen autism. And hopefully tie together some of the themes of this conference regarding going from biology to behavior. So why do we screen? We screen because conditions that are common can be identified and intervened with. So to introduce a screening program, you want to look for things that are common. You want to screen for conditions that impact public health. And as we talked about with ADHD, it's certainly impactful. And you all know by virtue of your presence this morning that autism is impactful on many aspects of life and health. And we want to screen for conditions where interventions may improve outcome if detected early. And that really is the impetus behind autism screening. Screening tests have to be reasonable in cost and be capable of identifying a high proportion of affected individuals. Now, we all know that autism is common. We managed to speak together for 3 days with only mentioning once the prevalence of autism. Dr. Pshorsky mentioned it the other day. It's found in 1 in 44 children born in 2018, assessed in 2018 through the CDC. The prevalence ranges somewhat by location. So again, this goes back to the comment that you find what you look for. And the prevalence, as many of you know, has had a reported increase over the past 4 decades. And that increase in prevalence is somewhat related to changes in definition, increased awareness thanks to family organizations and public health campaigns, and the need for diagnosis to access effective intervention. And that's the key, that to get intervention, you have to find the children who need it. And then lastly, a real focus on screening programs. The reason that you look for autism early is that there are lots of medical comorbidities. For many of you participating, you know that your child had problems with sleep and feeding long before anyone was worried about their language. So identifying treatable comorbid conditions that improve quality of life is important. And then, as we've been talking about for the past hour and a half, the impact of ADHD and anxiety on daily function is significant. So we need to identify the real reason behind behavioral symptoms so that they can all be treated appropriately. And then a topic that's been talked about in past Skirboll conference is the impact on the family health of children who have complex needs, including sleep and hyperactivity. We know from Dr. Pshorsky and Dr. Ko yesterday that autism is a costly diagnosis. It's costly in terms of parent stress and health resources, but it also is costly in terms of educational resources. And we believe that treating children early will minimize the resources needed in the future and have many, many more individuals with autism successful in the workforce. One of the reasons we screen is because we believe that intervention is effective, not necessarily curative, but effective. And it's most effective if intervention is early, intense, and includes the family. Family is the key word. You all know that services are provided publicly through early interventions through the county for children 0 to 3 across the United States, and that preschool, your school district takes over as the purveyor of intervention for children 3 to 5 before they enter formal schooling. What has been alluded to previously is that community-based interventions, we know, make a difference. They've not been studied robustly. We know they make a difference, and the study that Lynn Cole was talking about in terms of looking at ADHD and community treatment is critical for us to understand that aspect of care. We know that interventions targeting of symptoms delivered in research settings for very young children do improve outcome measures. And if any of you have young children who have challenges with acquiring language, we do have studies comparing research setting delivered interventions right now. So please join our research registry so that you can access that opportunity. But research delivered settings have more consistent and more intense intervention. There are lots of barriers to autism screening, and it has to do with time. Most of you are parents of children with or without autism. You know that your well child visits with your pediatrician or family doctor are brief. Screening has a cost. Screening tests need to be appropriate across cultures and languages, which they are not necessarily currently. Screening tests need to be formulated so they're accurate. And something that many of you may have experienced is that you get a positive screening test and a clinician may be uncomfortable or not aware of what to do next. So it's very important to us to train both nurse practitioners and pediatricians in our training programs so that they do know as they enter practice. And something that is well known to all of you is that there are limited services. So knowing how to guide families once you have concern about autism is an important part of clinical practice. Through the American Academy of Pediatrics, we have all kinds of screening that we do. And you know, in your primary care visits that you get screened for vision, you get screened about car seats, you get screened for hearing, you get screened for all kinds of things. And general developmental screening around language delay, motor delay, and other aspects of child development starts at 9 months of age. And formal screening is recommended at 9, 18, 24, and 30 months. But this is complemented by surveillance. And what surveillance means is recognizing when milestones occur, what is normal for children at different ages, and when we need to be concerned and seek help. And this enters the when do we screen question. We screen because we know that there are certain social milestones. We know that children at around a year of age respond to their name. By about 14 months, they begin to point to show other people they're interested in things and understand other people have a different point of view. And by 18 months, beginning pretend play is identifiable. What I do want to point out is that ongoing surveillance is necessary because children who have autism but have higher cognitive abilities may not demonstrate any sort of differences until the demands of preschool or later, when the social expectations of school and the environment are more sophisticated. I want to point out some terrific support tools that the CDC, the Center for Disease Control, has online that look at social milestones. It's in the Learn the Signs Act early website. And this talk, like all the others, will be included for your review on our website. And what the CDC reviews for us are these social milestones, as well as the better known motor milestones that parents record. There are other approaches to thinking about social milestones. And as I pointed out, the Autism Navigator is one other approach that uses narrative and online tools to help families identify when concerns arise, whether or not it may be atypical, and gives you some strategies what to do. So we recognize in terms of milestones that babies' brains are programmed to be interested in sharing activities with you by about 16 months of age. Young children are interested in pointing and gesturing, and this is cross-culturally by about that same time. That children who don't begin to play may have other reasons for not playing. They may have problems with vision. They may be isolated because of hearing. They may have motor delays, but not playing, not having imitation by 16 months is something that you need to bring to your clinicians, your pediatrician's attention. And if you're not interested in the world around you, rituals may emerge to give order to your world. And whereas young children will have some just so behaviors, they like things to be similar. Ordering and being unwilling to tolerate change is something that may be worth talking to your clinician about. And then there are the whole set of sensory differences which become evident as babies become toddlers. So how do we screen? Well, these developmental milestones in social behavior and play that we just talked about are things that we can ask parents about. Parents and caregivers are there to observe their children all the time. They interact with their children, and we take your observations extraordinarily seriously. What's become a real push is including daycare and preschool teachers in finding out about social interaction and communication through questionnaires and narrative, because they often spend a lot of time with very young children in social settings. And we also do ongoing surveillance in primary care, that in between visits and with other narrative concerns that parents bring up, the primary care provider, the pediatrician or family doctor, nurse practitioner, really needs to delve deeper to find out why the concern is present. And as Patty Corbett-Dick mentioned earlier, if a child has sleep problems and is inattentive, is unavailable to play, treating the sleep may be the issue. In terms of biomarkers, which is the tie to the first day of the conference, and also one of the reasons why we're talking about screening today, is that there are emerging ways to go beyond the questionnaires. Many of you have seen the MCHAT, the Modified Checklist for Autism in Toddlers, which is a 20-item pass-fail questionnaire, which is used in primary care. It's free. You can get it online through any number of screening websites, including the MCHAT website. And it's not designed as being a flat yes, no, your child has autism. What it's designed to do is to be an entry point for a discussion. That for any of these questions that are positive, the clinician is supposed to use a standardized set of questions to pursue why that question may be positive. Is it because of motor problems? Is it because the parent didn't understand the question? Is there a language barrier? So the follow-up questions are critically important to interpret the MCHAT. And for children that are either 18 or 24 to 30 months of age, a positive MCHAT is reason for pursuing further through more evaluation to figure out why the parent is seeing these concerns. That depending on the score cutoff, the child may have autism, but it's a very good screener for some problem. And even though this conference is about autism and autism is on our brain today, there are lots of reasons why children need intervention. And whereas the MCHAT is not a screen for language delay, it will pick up children with language delay and other reasons for early intervention. So it's your entry point into the system. There's a lot of interest right now in saying, okay, we have all this information in the electronic record. We're collecting all this information from questionnaires. Is there a way that we can use data and data science to figure out which children really have autism and screen out the children who have other things? And I just want to let you know that this is a really good idea, whose time has not quite come yet. That there is an FDA approved device, and approved means that they can sell it because it's not harmful, but it doesn't necessarily identify autism. But it combines parent questionnaire, a smartphone video, and then trained observers who look at the video at the company to put this information together. And I think that one of the reasons why this is so important is that in large areas of the country, there are no assessment clinics. And many of you know that we're deluged in assessment. So this may be a way to help triage to intervention. And I think that it's something that we'll need to keep our eye on. And this is my prompt to say that if you have concerns about your child, even if you don't have an autism diagnosis, the concerns are real and valid, and going to early intervention and or preschool for assessment and appropriate intervention for delays is indicated. Now, for those of you who were here on Thursday, you know that there's a lot going on biologically related to the symptoms of autism that we are just beginning to understand. And the physiologic measures like EEG, which you see, the baby here has electrodes on their head, may have utility in the future of helping identify children at risk because of brainwave pictures. that are characteristic. Again, it's not ready for prime time, but that is something that we're very hopeful will be promising. It doesn't meet a lot of the criteria for screening in terms of being cheap and available, but it may help us understand how to diagnose more effectively at younger ages. Similarly, the differences in eye gaze, what babies look at, may differentiate some children with autism. With our conversations about ADHD this morning, you know, that babies who are distractible may not look at what you want them to look at as well. So that there's a lot more work that needs to be done to tease apart reasons why these the data may be related to autism or not during these tests. There's studies looking at toddler vocalization using electronic media. And lastly, MRI, which is not appropriate for screening at this time because of the cost and the need for sedation. There's a lot of interest in genetic biomarkers, biologic reasons that may be associated with autism in terms of brain development. Many of you have had neurogenetic testing. There are actually 1,000 or more genes that are associated with autism and other neurodevelopmental disorders, including ADHD. So that genetic testing is not diagnostic of autism. Only the clinical diagnosis is diagnostic of autism, but knowing the genes may help identify both prognosis, what's going to come, and associated medical conditions. And something that is being researched right now, including in our clinic, is whether or not salivary, so saliva samples for microRNA might identify children with autism on a screening basis. And the ACN-net that Lynn had talked about in terms of the PCORI study is also collaborating to look and see whether microRNA in saliva may be a way to screen for autism. Now, many of you remember, and most of you don't, from your 10th grade biology, that DNA is the genetic material, the building blocks in our cells that tell us what color our eyes are going to be and how tall we're going to be. And that DNA makes proteins by the intermediary of RNA. And the microRNA that we're looking at in this study silences the activity of RNA. So this would be something that potentially would be a mechanism why some genes cause autism in some people and not in others. Again, it's too early to say that there's going to be a simple saliva screening test. And as we talked about this morning, there are lots of common co-occurring conditions in autism. We don't know whether these would point to specific symptoms within autism, like in the early studies, that some were associated with repetitive behaviors. When you if you have very young children and you're seen in our clinic, you may be asked to participate in this microRNA study so that we can take another step towards looking for biomarkers for autism, so we don't have to do paper and pencil screening. This is just how you get a saliva sample. There are lots of other biomarkers that are under investigation. Again, most of them are not anywhere ready for prime time. Things like untargeted screening of blood and urine for biochemicals, immunologic markers related to either prenatal or postnatal events. The microbiome is the bacteria in stool or saliva. But I want to stress that the diagnosis remains a clinical one. As both Ken and Patty said earlier, these are clinical diagnoses, and that there also is a high comorbidity of other symptoms that are neurologically based. which is why it's so important that research in terms of biomarkers be done carefully. So in summary, why do we screen? We screen because it's common. Early identification, early diagnosis, earlier intervention leads to improved quality of life and outcome. The goal for screening is for equitability in diagnosis and access to services. Who do we screen? The Academy of Pediatrics recommends universal screening with a population prevalence of 1 in 44 and autism found across all racial, ethnic, SES groups. It's really important that screening occur in primary care with ongoing surveillance as children enter school age and older. Some children are at higher risk, so that siblings, premature babies, and other types of exposures and genetic syndromes that are comorbid do need heightened surveillance. When do we screen? We screen when these milestones come online, when they're biologically programmed, such as using gesture, looking at things that we expect other people to look at and pretend play, with the recommended times for screening being at 18 and 24 or 30 months. But anytime a family member is worried, it should be taken seriously. How do we screen? Clinical surveillance, the use of valid questionnaires. The MCHAT, the Modified Checklist for Autism in Toddlers, is the most commonly used one. The POSI is used in the RRH system. And making a timely referral for diagnosis and services are critical parts of screening programs. And don't wait for a diagnosis to make a referral for symptomatic treatment. Biomarkers may permit earlier identification, more accurate identification of risk, and more rapid diagnosis in the future. We're very excited about that possibility. And the punchline is don't defer. That if you're worried, let your clinician know. If you're an educator or therapist and you're worried, let the parents know so that additional diagnostics can take place. And at this point, I'm going to stop sharing and we have time for questions.
Yes. All right. Thank you, Dr. Hyman. I'm going to share just one more time. So we had some questions about resources that the presentations, the slides, and other resources will be available on the website. And then because we just talked about a couple of research projects that are coming up, there is, again, the link in the QR code if you want to be a part of our research contact database. And then a reminder that we welcome your feedback. And so please fill out the survey link that you get. In that survey link, you will be able to request a certificate of attendance. And then in the chat, if you are a psychologist who would like to claim continuing education credits, there is a link that you can go to specifically for the psychologists on the webinar. And now we've gotten a lot of really good questions and we have some time. So the first one I wanted to pose is along the lines of resources. I and many other people were interested, Dr. Shamlian, in your executive function resources. And Dr. Shamlian shared some resources in the chat for young children to build executive function skills. And some follow-up questions were about resources for adults, and then also how to communicate with school districts who may be less attuned to recognizing these executive function deficits and providing supports. So if you could share your responses to those, that would be great.
I'd be happy to. So some of these resources that we're kind of asked about with regard to, you know, would some of the things that I've suggested in as resources, would they be appropriate for educators as well? And I would say you could actually think about maybe there are some very specific things that you could target for educators. These are things that are, again, maybe best accessed through different kinds of resources that are kind of typically are verified. So I kind of provided in the chat some things related to like Attitude Magazine, which I do trust, and things like understood.org, which is typically really quite reliable. And so you can actually search things specific to the audience around executive function, and there's materials that are available out there. Depending on the audience and kind of like where they're at for ready to adopt some changes might change how those are shared and what they consume. I saw the question about, we understand that we have all these great executive function suggestions for kids. What about, parents? We talked about in our talks irritability and kind of like maybe we struggle with something, maybe it's something our kid struggles with too. And we're just starting to realize, and put some labels or terms on these kinds of things that we struggle with as parents also. And obviously the nature of like what the tools are and how they look would change. I think many of the ideas behind some of the tools really probably just need a bit of an upgrade for adults, right? And so some of the suggestions and tips, again, you could probably search, again, through some reputable sources that might guide you as an adult for what you could do specifically with your adult kinds of responsibilities and tasks. But maybe we're not using a visual with cartoons and other kinds of like fun stuff on it for a checklist or just other things, but we are kind of figuring out, we need a system for us to keep track of what we need to do for, that day, for maybe even managing our child, make sure that they've got everything covered on their things to do. And so they can kind of go hand in hand. It's just more about making it age appropriate. And I think that the techniques and kind of like the tools really are probably more similar than different. And again, just to point out something in the chat, I did provide some specific kind of links if you're interested for videos or also websites, and maybe a free ebook that I actually love and use quite a bit around executive function that goes through the story of Josh as an example. These are great things that I think parents have responded to in the past.
Great, thank you. Along those lines, so CHAD, which is something that was asked about for the medications, they have posts relevant to adults. But while we're pursuing these resource lines of questions, Patty, people had questions about where can they access the CHAD resources and the medication decision aid toolkit.
Sure. So so on the Autism Speaks website, so www.autismspeaks, there is a link for toolkits. And so within that, I have a link on a slide, so that will be posted. But in the meantime, just, a Google search and then find the section where you select toolkits, or I think you can just Google Autism Speaks medication decision aid and it will come up. And the other one is called Medication and Autism Safe and Careful Use. I really think if you just Google Autism Speaks and those, you'll come right to a link for those. So CHAD is children and adults with hyperactivity and ADD, CHADD. It's a huge website. It's adults and children. Also understood.org, which Dr. Shamlian, I think, referenced, are both great resources for parents themselves and children. So CHAD, CHADD, and there's a medication. It's called ADHD meds. It's a printable medication chart. I hope that helps for now, but these slides will be posted.
Thank you. And we had another medication question while I have you, which is, what might you look for to decide if there is intolerance to a stimulant in a child? What might some of the things they would show you?
Yeah, so some of the kids that really just don't do well on a stimulant might have significant irritability or tearfulness. I think of sort of the mood as fairly intolerable during the period of treatment, not just, as it's wearing off, because sometimes that just requires some tweaking of the duration or the dosing or timing. But kids who are just irritable or super tearful on it, I think that would be fairly intolerable. But a lot of side effect tolerability has to do with sort of the medical status of the child. So a mild appetite suppression might not be a big deal for some kids, but if it's someone with really a low body mass index and some really significant nutritional problems, even a small appetite change could be really significant. So I think it's really about kind of the experience of the child and the family. But the classic are, I would say, irritability, appetite decrease, and sleep onset delay.
Great, thank you. And I will pose this one to Patty, Lynn, or Ken, actually, whoever wants to jump in on defining the difference between hyperactivity and impulsivity. Are these interchangeable, or are they just generally co-occurring? And then a related question was that people have received a separate diagnosis of elopement, and how does that tie in with everything else? And is it something that can be improved with medication?
I get there's a medication question. So do you want me to
Sure.
take that?
Yep, you can take, you want to take that? Sure.
Yeah, or anybody else can jump in, but hyperactivity I think of as motor movements. So fidgeting and squirming. And I think of it as developmental. So, what do we expect of a 3-year-old? That's why we try not to give the ADHD diagnosis, because we expect a 3-year-old to be climbing, running, jumping, right? But if there's a 25-year-old in your exam room who's climbing on the exam table, I think you'd know there's something probably more than ADHD that's a problem, because it's developmentally going to change. So the developmental context and the age matters. But this is in children is typically restlessness, climbing, talking excessively or out of turn, out of seat. The motors like on the go, can't put on the brakes, trouble waiting. And then impulsivity, yes, there's an overlap, but they are distinct. Impulsivity would be when someone reacts too quickly, like there's no pause between, an action and a reaction. So it's kids acting before they think. They can't inhibit that executive function that Dr. Shamlian talked about. They can't inhibit their behavior. They might blurt out, have outbursts. And that might include aggression, but this can lead to risky behavior, right? So this would be like the teenager who, has car accidents, the teenager who begins to do dangerous things. That could be, sort of an impulsive piece. And elopement, I think, can be associated with either hyperactivity or impulsivity, but we know it's a huge problem for children with autism. And we do consider it part of every visit to talk about the risks, because even children that we don't think will elope may wander. And so I hope anybody else want to jump in.
I think that was a great answer. And I think probably medications can be helpful to the extent that they treat the impulsivity or the hyperactivity that might be driving the elopement, but don't treat the behavior in and of itself.
And they wouldn't help with a child who has poor judgment. Right. So if you just don't know about running in the street, the medication likely isn't going to fix that. It might help you slow down, but it's not going to teach you safety.
Great. Switching gears a little bit, because we have only a couple minutes left, and I want to hit some different topics. So Dr. Hyman, the CDC recently changed the milestones and updated them. And there's a question about how that will impact early diagnosis for autism or ADHD.
So that refers to Learn the Signs Act early recently changed the timing. This is based on more current research. Previously, Learn the Signs listed the 50th percentile, so half of children reached milestones at any given age. Now it's the 25th percentile, so that if you are not reaching, if your child is not reaching those milestones, they're more likely to need assessment. It should not affect either ADHD or autism diagnostics, because the screening tests the clinicians use and the diagnostic tests are really not based on these milestones. But it's a useful tool in educating families who may not be aware of milestones beyond walking.
And then another question for you was, do you know the prevalence specific to New York State of autism? They quoted California as 1 in 26.
So the reason why we know state prevalence is because those are states that have CDC studies that are going on right now that are case finding studies. So no, we do not know the prevalence in New York State, but the participant correctly identified that states that have more services and more awareness and clinicians are finding more autism. So we would anticipate that New York is much more like California and New Jersey, which are participating states in the CDC surveillance registries.
All right. We had a follow-up question, which is, what is elopement? And so that would be someone who runs off, something catches their attention, or they might just open a door and wander off. And so we ask a lot of questions about that because of the safety implications. And then we have we're a little bit over. I have one more question for Ken, which is trying to differentiate when a behavior is coming from ADHD or autism, like an internal biologic causation or a functional response to the environment, things like trauma or something else that is in the environment triggering a behavior.
Yeah, and the short answer is that's a tricky question. And yes, it really kind of depends on really the family history and the history of the child. I often try to encourage people not to get stuck on exactly, we want to understand whether trauma is part of the picture and any sort of adverse childhood experiences, for sure. It helps us explain what the child's behavior might be in certain situations. Ultimately, we know what's shared with us. We use that to kind of help inform our general understanding of the child and then tailor interventions. And ultimately, we treat what we see. And so with understanding, we can understand and have compassion. And it does help formulate some of our treatment, but we can treat usually kind of like what's going on in terms of how we're observing the child and what they're doing.
Thank you. And Sam just posted the resources in the chat, and a reminder too that trauma-centered care was covered in a talk yesterday. And so some of how that relates with autism and how to approach that might be helpful from that talk as well. Thank you for the compliments that people have been enjoying this conference and found it informative. I'll ask one last question, which is whether we, one individual has noticed that in adults, they see more attribution of mental health diagnoses than diagnosis of ADHD, and therefore more treatment of antipsychotics rather than ADHD medicine. And do you think that there is going to be a change in the future? I'll give that.
So if I can answer this, yeah. The answer is we hope so. And that part of our very active training programs is so that residents in medicine and medical students will have a more robust understanding of developmental disabilities.
Wonderful. All right. So with that, thank you for all of the positive feedback in the chat. Again, fill out your surveys and give us more feedback and enjoy the rest of your beautiful Saturday. Thank you for spending your morning with us.